My name's Judith Cave, and I'm one of the oncology consultants here at Southampton. So obviously I know you're not all treated in Southampton, but I know I can see some familiar faces, so that's really nice to see people. I always feel really honoured to be invited to give these talks, because it's rare in my position as a doctor to get a chance to speak to a group of patients, especially a group that's as well informed and motivated and positive as you guys. So I'm really grateful to be invited. And also I would say that personally I've had a lot of support from Planets over the years, so I'm very grateful for that as well. It's always hard as a doctor knowing what to say in these settings, so I really hope that I say something that is, over the next half an hour, that's at least useful for some people, some of it. I realise that a lot of it won't be relevant to everybody. It's really difficult to say one thing that's relevant to everybody. What I've decided to focus on, and is the noise okay? Can you hear me all right? Yeah, okay. So what I've decided to focus on is a research update. So I'm an oncologist, which means I give treatments that are what we call systemic. So in other words, it's drugs, either tablets or injections, that go to the whole body and treat the disease everywhere it is. So that's my job. And obviously I can't talk about the whole of those medical therapies for neuroendocrine tumours in half an hour. So what I've decided to do is have a very clear focus on the future direction of research in NET tumours. And I hope that will be helpful. It's very much future focused. Because I'm a doctor, obviously I'm totally programmed to use jargon, so if I say things you don't understand, please put your hand up and interrupt me. Don't let me just carry on thinking, what is she talking about? And I'll try and explain it clearly. And yeah, off we go. So this is what I'm going to talk about. So I'm going to do a real long glance into the future. I got my crystal ball out and I've thought about the next 20 years of cancer research and what will it look like. So that's the first thing I'm going to do. Then I'm going to just turn a quick bit of attention to how can we speed up this research in NET tumours, because I think it's not as quick as we want it to be. And then I'm going to focus right down on the stuff we've done in the last year or two in Southampton. So especially in this first bit, I'm going to use the word cancer a lot, meaning generically cancer research. But obviously I realise that term isn't always totally applicable to NET patients. But I'm going to use it if that's all right, because a lot of what I'm talking about is about oncology research generally, not just specific related to NETs. So immunotherapy. Has everyone heard of immunotherapy? When I say it, do you know what I'm talking about? Yeah. Just in case there's anyone who hasn't, I'm just going to explain what I mean. So I've been a consultant for 13 years, and probably maybe about 10 or 8 years ago, people first started talking about immunotherapy. And it has literally transformed my working life. I cannot tell you how much difference it's made to the world of cancer in general. So and when it first came out, when the idea of immunotherapy first came out, there was a lot of excitement in the kind of the press, and people even started to say, Time magazine started to say, this is going to be the cure, it's going to be the answer, cancer's a thing of yesterday. And obviously that isn't where we're at 10 years later, but I think we have made a lot of progress. So immunotherapy is basically a drug which makes your immune system attack your illness, okay? Now, I'm going to just tell you a little bit about the immune system. So this orange thing here is a T cell, and that blue thing there in that cartoon is a cancer cell. And we know that T cells, your immune system, can tell that the cancer is there and that it shouldn't be there, and it can attack it. And of course, your T cells attack all sorts of other things that shouldn't be there, like COVID and other infections. So we know that T cells can do that. And that is news, because if you go back like a few years, people used to think that one's immune system couldn't see the cancer because it didn't regard it as foreign. It didn't regard it as something that shouldn't be there. It thought it was part of you. But we've learned now that isn't true. So the immune system can see the tumour. This is very important. And so an immunotherapy, a drug, is a drug which basically tells your immune system, get on with it, do something, fight now, now's the time, off you go. And immunotherapy drugs are used for some neuroendocrine tumours, specifically small cell lung cancer and Merkel cell carcinoma. These are rare subtypes of NETs. So we are using immunotherapy in NETs now, but not for most patients. Most of my working life is spent treating patients with lung cancer, and I use immunotherapy all the day for that. But trials of immunotherapy in NETs have been disappointing, and that isn't my word, that's from a review that was published last year, with basically very low proportions of patients benefiting. And this is a matter of great distress to me, and I'm sure to you. There have been a lot of trials done, and sometimes one will look promising. So there'll be a drug, and I give a list there that somehow looks a bit more promising, and then the problem is no pattern emerges, and we're not really cracking this, I don't think, at the moment. So there are trials going on at the moment looking at giving immunotherapy in combination with other treatments, so trying to give it with chemo to sort of both boost the benefit, or giving chemo first, then immunotherapy, or chemotherapy, radiotherapy first, then immunotherapy. So there's all this research going on looking at how we can try and improve the situation. But the bottom line is we need to understand why the immunotherapy isn't working. Otherwise, we're never going to crack it. So we need to understand the biology of what is going on there. And actually, we did some research in Southampton looking at exactly this question, which I think has been presented to a conference before, so you might have seen it. But essentially, to summarise it very crudely, if you look inside the tumours, you do not find the T cells. So the T cells can't attack the tumours if they're not anywhere near it. So either they're not noticing it's there, or they're not getting in there, they're not penetrating in, or something about the way the tumour's behaving is sending them away. So that is the problem for NETs. And bear with me, I'm going to just do a little bit of teaching you now about the immune system and how it works. So some of you will know all this already. I'm going to try and make it understandable. If you fancy a 2-minute nap, micro nap, if this is too much now. So here's a T cell. Okay, that's not a good idea. Have I got a pointer? Yes, I thought, red bit. Red bit, thank you. Right, here's a T cell, and here's your lymph node. Basically, you have to imagine the T cells are like sniffer dogs. This isn't my analogy, it's Professor Ottensmeyer's, but I like it. So they're like sniffer dogs. They go around looking for the thing, and each T cell will have a thing it's looking for. That's the antigen. So T cells they're not general, they're very specific. They're like a fire dog that's trained to sniff out accelerants. They just look for that one specific thing. So there is this antigen which this T cell has been told to look for in the lymph node. So the T cell goes to school in the lymph node, and it learns this is what I'm looking for, this red antigen here, and then it goes off in the blood vessels, round the body, and when it comes near to cancer, if the cancer has that antigen on the outside of it, the T cell will attack it and kill it. Okay, so that's how it works. They learn what to look for, they float around. When they find that specific antigen, off you go. Now, the thing about T cells is they have on switches and off switches. So in the lymph node, they have this on switch here called CTLA4. They get turned on, off they go. But they also have off switches. And this is where it gets clever. So the cancer, what we know now about cancer is that it basically has learned how to switch the T cells off. So it sends out this little thing called PD ligand 1, which docks onto the T cell receptor, and the T cell basically shuts down. So the cancer sends out a message saying, don't worry, nothing going on here, everything's totally fine. And then the T cell goes off. And so that's the problem. And the drugs we use, when I say immunotherapy, most of them are either drugs that hit the on switches here or prevent the tumours hitting the off switches here. So that's basically what I'm talking about when I say immunotherapy. So now you can all wake up again if you didn't want to know cell biology. Okay, so how can we turn up the volume on this? So I've told you that I use immunotherapy in lung tumours all day. And I've told you that it doesn't work very well in neuroendocrine tumours. How can we just rank up the volume, basically, and get better at this? Okay, so there's a thing called a CAR T cell therapy, which I'm going to just explain to you, which I think you might have read about and you might read about in the papers, and which I think is a very promising type of immunotherapy. And it works like this. So you remember I showed you between the lymph node and the tumour there was the little T cells floating around in the blood. So you all have T cells floating around in your blood. What CAR T is, you take out the patient's T cells and then you muck around with them. So you basically genetically engineer them to fight the antigen you want. So it's basically the equivalent of taking out the T cells and reprogramming them to look for and destroy the things that you want them to look for and destroy. So you genetically engineer them, and now they're called CAR Ts, chimeric antigen receptor Ts. So they're T cells that have been genetically engineered, and then you grow them, you make millions of them, and you make them a bit angry with something called interleukins, and then you give them back to the patient. That's called a CAR T therapy. And here's a cartoon of it, which doesn't project very well, sorry. But basically, it's a quite a long process. You take the T cells, you make them in the lab, you grow millions of them, you give them back to the patient, and then hopefully they do their job. And this is really promising, and in lymphomas, for example, is already in the clinic. So this is something probably like the next generation of immunotherapy. Now, the problem with it is that it all relies on being, you know that little red dot I showed you, which is where you teach the T cell what to look for? It basically relies on you being able to reliably know what antigens are on the tumour cells. So it's like a lock and key. Your genetically engineered T cell will only be able to fight the thing you've told it to fight. So in order to make a CAR T treatment for a patient, you need to know exactly what antigens are on their tumour cells. Not only that, but they need to have the same antigens on all their tumour cells, because otherwise you might just kill some of them, and that's a bit pointless. So this is, well, it's not totally pointless, but it's not what we want, because this is a really quite a risky and toxic therapy. So if you're going to do it, you want a chance of it being a cure. Okay, so this little cartoon here shows you that this is like a lock and key. You need to know the antigen you're looking for, and that is the problem. So with some tumour types like lymphoma, for example, you can say that all the tumour cells will have one particular type of antigen on them, and with other tumours, like definitely lung cancer and almost certainly neuroendocrine tumours, it's very variable. The tumour cells look different on the outside, and it's much more difficult to train the immune system to hit them. And we're doing a bit of research at the moment in Southampton, which is in lung tumours, which I want to show you about, because it's like, I think, the next thing. So instead of getting a clone of T cells that all look the same, what we're doing in this research project, and I say we, but really it's run by a company called Achilles in London. We're just doing the treatments, we're doing the work, we're doing the clinical work. So essentially, what you do is you take the tumour out, and you take the patient's tumour out, and then you look and you work out T cells that are already attacking it. So instead of genetically engineering T cells, it's like the natural T cells from that patient, and you work out which are the most likely to attack the most tumour cells by using a very clever thing called this Peleus technology, which they've patented, and then you grow those T cells. So it's a much more patient-specific approach, and I think it's very promising. And we're one of the first centres doing this in the world, one of the first groups doing that in the world. So it's very exciting, but at the moment it's in lung tumours, not neuroendocrine tumours. So what about T-cell treatments or cellular therapies for NETs? So I've just told you about T cells, about CAR T cells, about cellular therapies. It sounds really exciting. Is it going to be a reality for NET patients? At the moment, there's nothing existing. There is, I think, one company who has one potential compound that's around. So I think there is no doubt that trials of cellular therapies of CARs are going to be expanding exponentially in the next few years. So my goal really in Southampton is to position myself such that when those trials come available and I put my hand up and say, please can I run this study? They say, oh yes, off you go, Dr. Cave. So I need to show myself as being basically able to do this work. So that's what I'm focusing on at the moment. So that's CAR Ts and immunotherapy. Any questions on that? And then I'm going to move on. Yes.
Can I just ask?
Yes.
So obviously, immunotherapy has been around for a long time, but
yes.
really predominantly in the last 10 years.
Yes.
And a lot of the oncologists are using the same branded drugs.
They are.
And they're trying it on different other cancers.
Yep.
Skin cancer, kidney cancer.
Indeed.
They were the first,
yeah.
etc. So would you say that CAR T is where immunotherapy was 10 years ago?
Yeah, maybe 15, yeah.
Okay. And based on that, would you say the excitement is bigger now for CAR T than it was for immunotherapy?
I think it's about the same. It's as exciting, but it's like a next level up, I think. I'm hoping it's a more risky treatment. It's a more expensive treatment. It's not going to be for everyone, but I'm hoping that for the lucky ones that it is suitable for, the rewards will potentially be better.
Yeah. So, thank you. So Christian Ottensmeyer said that when he was talking about immunotherapy a couple of years ago, that he's like a child in a sweet shop with immunotherapy, and he's got a jar, and there's only you need to research it, you need to you do whatever you do. what makes you think that actually, rather than carrying on with immunotherapy, you know, testing with nets is not as good as CAR T? What's your, is it just
because of the results so far? You know, I just, when you look at what's been tried, the drugs we have, the immunotherapy drugs we have, if you give those to patients with nets, it's not as well. It's not. It can. There are sometimes good results, but it's not consistent. It's not reliable.
No. And at the international, one more side. No. And at the international conference, when they just recently we've been talking about this, where they were highlighting this.
Yeah.
What types of cancer was that one with CAR T?
Yeah. Well, with immunotherapy recently at the international conference, there was their thing about some inherited bowel cancers, which was very exciting. Yeah. So yeah, I like Christian's sweet shop analogy. You know, it's like at Christmas every year. You know, there's a new one where you think, well, it works for this group of patients, or it's for it's good. I mean, you know, in my job, new treatments that really work is like it literally doesn't get better than that. Yeah. It's brilliant.
So is there not? I'm trying desperately here. Is there a link? Obviously, we've got the bowel.
Yeah.
We've got obviously this new.
Yeah.
Is that going to affect NET?
No.
No.
Sorry. Sorry. Well, I did promise this was a look into the future. I mean, these are, you know, this isn't available now here. This is things that might be happening in the future.
But it's a start.
It's a start. And, you know, we need optimism, don't we? We need to believe in science, and because it's hard work, so we need to sustain ourselves with optimism. Okay, so now I'm going to just talk about a couple of other new drugs that aren't immunotherapy as such. So there's this thing called a harpoon, which I love this name. And now this is a different approach to the T cell. It is sort of immunotherapy. What it is basically, it's sort of like a magnet that pulls together the T cell and the tumour cell and tries to get them in the same place. So I think this is promising. And we were going to try a trial of this in small cell lung cancer. So I think this is this kind of approach where you basically try and, you know, I told you with nets, we don't see the T cells near the tumour or in the tumour. So basically using a drug to try and basically drag them together. A bit like, I don't know, a mother-in-law organising a date or something, I don't know. That sort of thing. It's like, come on. So that's one of the things. That's a different approach. Also, there are new anti-angiogenic drugs coming out. So in order to grow, a lump needs to grow its blood vessels as well. And so there are drugs which basically try to stop the lump growing its blood vessels. And those drugs are being used in the UK now in normal practice for pancreatic nets, but not for other types of nets. And there's a drug called surufatinib, which has been shown in other nets, not just pancreatic nets, to be beneficial. And that is in trial at the moment. So this is also promising. This is much closer to reality. But I think I said earlier, I feel like we really need to speed up progress because it never seems to be as quick as we want it to be. The challenges with doing research in nets, I think a lot of it is around the rarity, so it's hard to recruit large numbers to trials, and some of it's around funding. So the drug companies, if they've got a new blockbuster drug, they want to look for trials where there's going to be higher numbers. So it can be challenging. Not that we should give up, but I think we need to look for novel approaches. And I wanted to tell you about this, something I saw, which I thought was interesting, which is where they grow in the lab a thing called an organoid, which is basically a lump of tumour cells. Now, the clever thing about this is it's not just any old tumour cells, so they would grow the tumour cells from a particular patient. So essentially what they've got then is they've got in the lab a little bit of that person growing, and then they can test drugs on it. And this has only been done in 3 people, as far as I can find, but it's very exciting. And you can't see these graphs, but essentially they did this with 3 people. They grew the organoids, and then they gave the patient the drug, and they gave the organoid the drug. And they did find that they could tell by looking at the organoid which drug was most likely to work for the patient. So that's quite exciting, isn't it? So that's when I say how can we speed up progress, I think we really need real novel approaches. I'm not sure what time it is. Yeah, 10 minutes. So in the last 10 minutes, I'm just going to talk a little bit about research we've done in the Wessex Net group in the last year. And of course, it's been a difficult couple of years for research because of COVID. It has been really hard. But we've done our own local study called Quantums, which I'm going to show you the results. And we've also done a large international, we participated in a large international, what we call a phase 3 study, which is where you basically take 2 drugs you think are good and you put them head to head and you see which is better. And that, so we've done that. So the Quantum study, basically what we wanted to do there is we wanted to look at quality of life in patients with neuroendocrine tumours who had cytoreductive surgery, or TAE, which I expect will apply to a lot of you in the room. And we wanted to look, how long does it take people to recover from those kind of treatments? Because we hear a lot of our patients saying, oh, they didn't feel very well afterwards. And what we want to know is how can we inform people in the future what's likely to happen? So we did a very complicated load of questionnaires. We've been doing this since 2017, but we really just finished writing up the results last year. And we asked the patients to fill in 3 massive long questionnaires. If anyone in the room did this, thank you so much. So we asked the patients to fill in 3 massive long questionnaires every 3 months. It was a lot of work for the patients and for us collecting the data. And we use questionnaires that are known to be useful and reliable in patients with neuroendocrine tumours. So they ask questions that are validated for neuroendocrine symptoms. And what we basically found is this. So this was before the treatment. This was immediately after the treatment, and this was at 3 months. The red line is patients with neuroendocrine tumours, and the blue line is what you would expect if you send it to 1,000 of the general population. Okay, so the important findings are definitely straight after the treatment, people do not feel as well as they did before. I think most of you could probably have told me that already. But by 3 months, people are feeling better. And this was really reassuring to us that we are doing the right thing with these treatments and that, that benefit is quite sustained. So we were pleased with that, that, it's not like you feel worse for ages, it's just a short period. And we did a really much more detailed analysis looking at all the specific different symptoms, and I realise you can't see this very well, but I'll tell you, the 2 main symptoms were tiredness and diarrhea. They were the main symptoms that people experienced. And again, we saw those peak straight after the treatment, but then come back within 3 months. So we're pleased that we feel that this is almost, for us, it's like audit. We're doing all these things to people, and we're telling them they're going to feel better afterwards. Is this really true on average? And we're pleased that it is. And this was the study I mentioned that was the drug-to-drug study where we compared 2 drugs. We compared a very new compound called liposomal irinotecan with a very old-fashioned one called docetaxel, and the liposomal irinotecan was better. This was presented in America in the summer, and this was a lot of centres did this study. It wasn't just us. We were aiming for 102 patients, which doesn't sound very many, but it was really hard. And actually, we had to stop at 58 because of mostly the pandemic, but not just that. It's really difficult with these rare things to recruit a lot of numbers. So we struggled with that, but we did it, and hopefully that means that liposomal irinotecan will go on and be studied more. So, in summary, I do think it's definitely an exciting time for cancer research generally. I think in my working life, things have changed beyond recognition, and I'm really proud to be part of research effort in Southampton. And in coming specifically to the situation with neuroendocrine tumours, my goal really is to try and make sure that, first of all, I keep up to date by going to conferences. I hopefully know what's out there, and as a result of that, my patients and all of you guys will not miss out. And also, we try and run a good portfolio of trials at Southampton. Running trials is it's very heavy on resources, so we can't run every single trial, but we try to pick good trials that are going to be relevant to a best number of patients. And also, as I said before, to sort of position ourselves so that if something really exciting comes, we will be in a position to get it. And I think the most important thing I want to say is thank you to all the patients who participate in trials, all the relatives of the patients, because it's also all the travelling and all the work and all the extra tests and all the questionnaires. So thank you to all of you, and also thank you to Planets for funding and encouragement. Thank you very much.
Thank you, Judith. I don't know about anybody else in the room, but I wish I'd have tried harder at science at school. I've got a slight overload headache.
Sorry.
But it's a good headache. And lots of really important information and positive information there, which we're very grateful for. Has anybody got any questions at all for Judith before she shoots?
I selfishly have two. Sorry, guys. Do you mind just wait till we give you a
Okay, yes, sorry, microphone. Sorry, I forgot about that.
Sorry. Thank you. I selfishly have two questions. The first is more general, which is obviously recruitment's a challenge. What can we as the Planets family do to help with that?
Nothing that you aren't already doing. I mean, it's amazing. My colleagues around the country are so jealous when I tell them that I have basically a forum, a way of communicating, is what it is, so that if we do have things, we can advertise.
Okay, we're doing as much as we can.
I think you are. I mean, if you can think of anything else. Do you know what else I think? I think we probably need to start having more what we call PPI, so patient involvement at the kind of management end of setting up studies, primarily in the hospital. And really that is to increase the priority of net research up, because you see, I have to compete with all the other studies going on. And so, yeah, I think maybe that's one thing that I'd like to see over the next few years.
Thank you. My second question is more detailed on your graphs.
Oh, yes.
Sorry, a bit of a geek.
Yeah.
You showed how basically after 6 months,
Yeah.
people started to feel quite well.
Yeah.
And then you could see people sort of
Dip at a
dropping
year.
off and then coming back and dropping off.
Yeah.
I'll close the question by, was that because just that's the natural biorhythm of people, or other things were affecting the results?
Such a good question. So we've talked about this a lot. So we did see a bit of a dip in quality of life at a year. And my gut feeling is that that's probably because that's about the time to when people are needing another treatment. Because we didn't, often treatments don't last forever, then you need to have something else done. And of course, we don't have the numbers in that small study to really prove that, and also how would you in a way. But I think we definitely saw that it was around a year often before people were needing another treatment. So I think that's why that is.
Thank you.
Would that be scan anxiety as well?
I think you've got a very good point there, Neil, and I do think that, because one of the big things in the quality of life is around anxiety and how you feel. It's a very good, and because if you're having scans yearly, of course, and obviously the questionnaires often came at the same time as the appointments, and sometimes people filled them in the waiting room, which obviously was not the best, maybe.
Thank you, Michael. Excellent questions.
Yeah. Any other questions?
Yes. I just wondered if there was any research into the causes of this cancer. I mean, generally, smoking, obesity, alcohol, is it the same, or are there different reasons?
It is different, 100% different. You're absolutely right. And most of the research that's going on at the moment is concentrating on looking at the genome. So, and that, to be clear, that isn't necessarily just the inherited genes. It's accidental mistakes that happen in our genetics as we grow and age. And I think we're learning more and more about, how these things happen. So there is some research. It's not probably been my specific area, although we have done a lot of collecting tumours and banking them, and that means that we have a lot of opportunity to look at the genome, and there's a national project looking at this that we're part of. So the difficulty is knowing what to do with all the information. Is to get a lot of information back. But yeah, there is some. That's a good question. Yeah. Or we just get you a microphone.
Thanks, Judith. Great talk. You are trying to position yourself and Southampton so that we can take the opportunity of CAR T-cell trials when they come. What can we as Planets do to facilitate that?
Yeah, it's a good question. Well, to be fair, so I would say the hospital management is 100% behind this. They want to fund, they want this to happen, and I think that at the moment probably there isn't much more that can be done. So in terms of money, the hospital is willing to fund time. The cellular therapy trials are really complex and difficult to run, and you imagine that if you're taking cells and giving them to a patient, you've got to be 100% sure those cells are safe and that they did come from where you think they came from. and that nothing bad has happened to them in the interim. So that process is very expensive. And there's a lot of documentation, a lot of paperwork. So I've been doing a lot of learning about that. I think it's mostly stuff that we need to do. That's our, as a hospital, and we need to prioritise it.
Would we outsource it to the same labs that it's currently?
Yeah.
So we wouldn't do it in-house?
No. So in fact, you need a special license called an HTA license to generate the cellular therapy, which we don't have. Although we have, basically what I did is link up with the Royal Free HTA license, which was fine. But no, I think we will outsource it.
And that's not part of our ambition ever?
I don't know. It's a good question, and I don't know the answer. I think it may be one of those things that becomes more common over the years, that people do it themselves. Yeah. But it's certainly not an immediate plan. Okay. More questions over here. We got 2.
Do you not share information internationally then?
Yes, we do, yeah.
Like United States collaboration and stuff?
Yeah, we do. So we go to the American conferences. And,
good.
Yeah.
I thought, is it just yourself here and that's it,
No. Most of the research I do, I'm basically collaborating with a load of other people around. You can't really do this stuff on your own. The local stuff we did, the last one, the quality of life, that was just us.
Another thing, actually, Somatuline is what I take every month. I'm not sure if it's general on me, but everyone I speak to who take it, a few days later, they're not very well or something. But I don't feel that effect. Is there something wrong?
You don't feel that effect?
I know, I think I asked you before, but it doesn't seem to be. I mentioned to you before, it's a performance enhancement drug as far as I'm concerned.
Yeah.
But should I be that way?
Do you know, well, I'm going to answer your question with a general comment, if that's all right, because obviously I'm not familiar with all the details of your case, but I think there's sometimes patients believe that if it's not causing you any pain, it's not going to give you any gain, but that isn't true. Or maybe it is with Joe's talk later, but not with my stuff. Some people are lucky and they don't get any side effects, and other people are unlucky and they have a horrible time, and it doesn't correlate with benefit. So you can relax. The lady next to you had a question as well.
Thank you. I believe, back to sort of basics, I think you said that when you take the T cell and then you do something to it and you put something in it so that it can find the cancer gene and kill it off. That's the sort of way I understood you to say. Does that then mean that all of your T cells, when you inject that T cell back in, that all your T cells only are going to look for that, or are they still acting as a T cell, as a normal T cell, to catch the sort of bacteria and the flu and
that's
all of
such
that
a good
sort
question. So when I do the T cell therapy, basically, before I give the patient an infusion of the T cells that we've made in the lab, we have to give what we call a lymphodepletion. So we have to make space. So we have to give a treatment to get rid of some of the patient's T cells. Okay. Now, we try not to get rid of all of them for obvious reasons. But yes, you do need to make space for those new T cells.
One other, probably a silly question, but because the cancer cell has got this, he's hiding and you can't find me, I'm fine. Has there been any research onto how to do something to that, to make, instead of making the T cell more active, to lessen the hiding ability of the cancer cell?
There is definitely. So I haven't covered all the research, and there's a lot that's there is a lot going on in that. Okay. And in fact, that is basically the drugs that we already have. Those are that. Okay. They get rid of the cancer's hiding bit.
Okay.
Yes.
Thank you.
She says very technically. Thank you for great questions. Does anyone else have one? Thank you very much.
Let's thank Judith. Thank you.